Hello, everybody. And hello. Well, I say it like that because apparently I often say, hello, everybody, really quickly, and no one can understand me.
Yeah.
Well, anyway, today,
Introduce yourself
it's
first.
great. Oh, it's Brett here.
Yeah.
And today it's great because we have one of those limited opportunities where Phil, Martin, and myself are all together in the same room.
Yes.
So, g'day, Phil and Martin.
G'day, Brett, Martin.
It doesn't happen very often. We often have to do these Zooms, but it's nice to have us all together. And this time Martin's in Australia rather than us being overseas and meeting you there somewhere.
Yeah, nice to be over again. See my chums. It's good.
So today we're going to talk about a paper that's in press, currently anyway, in the Journal of Hospital Infection. It's called Timeliness of a Potential Automated System for National Surveillance of Healthcare-Associated Infections. Now, national surveillance, Phil, is something that's dear to your heart, isn't it?
Dear to my heart, but a long, long way from reality, Brett.
Isn't the new ACDC going here in Australia going to sort all that?
Is there an ACDC?
I don't know.
Oh, I don't know. I haven't heard of it. I haven't seen anybody there.
Oh, right.
I've knocked on the door and there's nobody home.
Okay.
So
I know.
Well, they're not
I
including...
missed
They're not
ZZ Top in Melbourne last night, so maybe ACDC will be a bit of a sticker.
The Australian Centres for Disease Control is what Phil's alluding to, which is something that has been promised and in the pipeline perhaps, but at the moment it's not going to include infection prevention and control, so it won't be including national surveillance
What?
for infections. No, that's a topic for another day.
Okay.
But Australia doesn't, unlike many other countries, doesn't have a national surveillance program.
no national data.
No, apart from Staph aureus bacteremia,
Yes, which...
which is probably a bit dubious.
yeah.
So,
And regular national prevalence surveys.
oh yes, there's one every 35 years. Or
What was that?
regular prevalence survey.
Point prevalence survey. Yes, we do it every 35 years in Australia.
Okay.
So,
once in a lifetime.
So we're not due for another one for what?
Well, I've done some in the UK, and it is onerous, and you wouldn't want to do it every week, but 35 years.
Yeah, well, would you, another 25 years, I reckon, Phil? Due for the next one?
having said that, though, the states can do some more regularly, and there is one coming up in
Yes.
Victoria in the next 12 to 24 months. So,
Yes, that's right. Anyway, so yes, that's probably why it's a bit of an interest. And Martin, you love the data coming out of the UK. You find it timely, accurate, all the things you want from a surveillance system?
Well, certain things are mandated, so you have to input them and provide information on. There has to be a certain amount of information there. But there are various voluntary surveillance schemes in the UK which is onerous, and it takes quite some time to input the data. So I think that's why UKHSA, which is the UK United Kingdom Health Security Agency, rebranded several times for Public Health England, etc., are looking at can they do some form of automated system to reduce the burden on infection prevention teams.
So just before we get into that, so we know Australia hasn't got one. What countries would you say hold up and go, oh, it would be great to have a system, a national surveillance system? Although Germany's got quite efficient.
the Krankenhausen
They've got
KISS.
KISS
Yep.
system, haven't they?
Yep.
Yeah.
And look, the CDC rely on data that's the NHS and through the set definitions, I should say, through the quality agencies there. I don't know if I don't believe they're automated. I can't imagine they would be with, it might be locally automated,
Sure.
but anyway, well, I'll speculate on that. I guess what we're getting at here is there's probably nothing springing to mind as to a brilliant system out there.
A real-time
real-time-
national surveillance
real-time
program.
national
Yeah.
surveillance system.
I actually have a sneaking suspicion that Wales has,
Oh, they've got ICNet, haven't
because they got ICNet, or they had ICNet, and they had a national system. So if you were flagged on one hospital, you'd be picked up in others. But I've got to be honest, I'm not exactly sure if they have got a completely automated system, because ICNet depends to a certain extent on how many interfaces you've got in your individual organisation to actually drag the data in.
they? And having a surveillance system, like a program that does it, is different to actually having a true national surveillance system, which does all the benchmarking, it does the control charts, it's timely, it allows you to to be able to usefully compare and understand trends.
It has a purpose.
It has a purpose.
It has a clear purpose. It's got to have a clear purpose, not just data collecting.
Yeah. Well, anyway, that was a very long introduction as to why we've talk about this paper. But what do they do, Martin, in this paper?
Well, what they wanted to look at how quickly different types of existing system data got into the system relevant to healthcare associated infection. So they then want to look at how feasible and what the potential timeliness is of a centrally implemented automated surveillance system. Just as an alternative to the current system where local hospital groups put the data in monthly. So, bloodstream infections, they're mainly concentrating on some particular gram negatives and Staph aureus at the moment, both MRSA and NSSA. But they're looking at the moment, at the end of the month, you have to sign off the data.
Yeah.
So they're just trying to work out.
So basically pulling it from laboratories.
And patient administration systems to get the demographic data.
And these are all different laboratories. Like, it's not one central laboratory.
No, it's not one central lab. So each local hospital has a lab it will use, whether that's owned by that own organisation or whether they're using a sort of central lab that covers a few organisations, but they are NHS laboratories.
Right.
Yeah, I
the
think
problem with them is often they will each have a different laboratory information system.
Yeah, different protocols, probably in IT. Yeah.
There are a number of different IT systems available, and so they're all slightly different. So
that makes that very tricky, doesn't it?
Yeah, it does.
So I think the crux, we'll just perhaps get straight to the crux of the paper where they wanted to examine the the timeliness of the available data. And
now when they're looking at bloodstream infections, antibiotic sensitivities, so they'll get that from the lab, and then they'll get the patient demographics and some basic information about admission and discharge data, that sort of stuff.
Yeah. And a lot of data. I mean, they included here a large number of laboratories to try and do this, and a large number of infection records and patient records that they accessed. One of the results was it took 1 to 3 weeks for 90% of bloodstream infection records pertaining to specimens to be available.
I think that's pretty straightforward, though, isn't it? If you've got a laboratory information system, positive blood cultures will be in there, all the antibiotic data will be in there, so that I think that's quite reasonable. That's available 1 to 3 weeks because microbiologists are busy signing it off.
Yeah.
So I think you would have that quite easily. But
the next one, up to a month for 90% of admission and emergency department dates for determining healthcare associated or community onset.
Yeah. And now we're talking about humans getting it.
Which you would think that should be reasonably easy data to ascertain, wouldn't you?
You would think so.
Yeah.
So a month isn't. Is a month helpful to determine whether something's healthcare associated or not? You're not going to be able to use that in real time locally.
Yeah. No, probably not.
No, not unless unless you've got a lot of patients who stay in hospital for a very long time.
Yeah. I guess it would pick up trends pretty quickly, potentially, but not going to probably help with clusters. It's probably not going to help with.
Be okay, and they look back. Case control sort of setup sort of thing.
Good for long-term trends, over a long-term period,
trends.
You can look at which way the organisation's going, etc. But it's not going to spot your outbreak. I think.
No, it's not going to alert you.
Yeah. But, a national surveillance system shouldn't be spotting an outbreak at a local level, unless things have gone very badly wrong at a local level. If you had a tap on the shoulder, have you noticed this? That probably wouldn't be good. Really.
We have noticed. Yeah.
It was also up to 2 months for 90% of inpatient diagnosis codes to be included.
Yeah.
So that's for risk adjustment.
Yeah, and that's a tricky one.
Up to a year.
It's absolutely humans going through notes.
And that's on discharge too.
That's on discharge.
Yeah, so you're presumably relying on coding data for that.
Coding departments in the UK are normally
Slab.
basement.
Yeah.
And they're trying to make head or tail of often written notes rather than electronic patient record. And things are moving better now, but it's not. It's not easy. That.
And there's also a lot of variability. So 10% of providers took up to 6 months to complete the submissions, and about 2/3 did not submit a record until the discharge date was present. And about 1/3 didn't until both the discharge and diagnosis codes were present. So I guess there's a lot of variability in it would seem through this pilot exercise about how quickly we can get their data in.
Do we know were these agencies told that this study was going on and this is what they were looking at? Because that might influence the timing. If you knew somebody's at the other end waiting for it, would you try and be a little bit more expedient? I don't know. But
Well, I mean, they do know people are waiting for it anyway, because you've got when it's month end, say the end of April, you've got till the 15th of May to submit and sign off. So it all has to be in by then. So that's fairly sharpish, but that's only giving you the bloodstream infection data.
Yeah.
Not the antibiotic sensitivities. You know, you don't, that comes out of the system differently. The patient admission date, and so they're trying to work out. I think the 15 days is to allow you to work out if it was hospital acquired or not. So that's a manual entry.
Yeah.
And it would take that burden out quite nicely,
Yeah.
really. But you're not going to get, and you're trying to make some sort of assessment as to what the underlying infection was. What was the bloodstream infection related to? Well, the nationals pulling out automatically wouldn't have that.
no, that's right.
And the authors make this point that while micro and patient records are loaded every day in the UKHSA, that doesn't mean that all the records on a particular activity date will arrive the following day, and organisations send their data in batches. And it means that the surveillance centrally would result in lower ascertainment in the present system, where hospitals submit their monthly cases on the 15th day of the month.
You batching because it's more efficient to just sit there and put a load in at once rather than log into the system and do one at a time.
Yeah.
That's a common sense approach, I think, really.
I guess how fast is fast, and the authors talk about how fast is fast, and we've probably already mentioned that, Phil, about it's a balance of getting the good enough data in to make sense of it, not too long, but equally you don't want rubbish data because people are presenting it too early.
That's right.
Or it's being automated too early.
I mean, there's a discussion, isn't it? Is it useful for local surveillance?
That's the key.
Yeah.
And what's the purpose of actually doing it?
I mean, I think make it easier and you'll get more information on more organisms rather than the specified organisms you have to collect information on now. And you may get better information on contaminants, but which is practice related, that maybe people don't always spot locally. But for day-to-day use, I don't think organisations would find this useful, but they may want to look at their trend if they're getting timelines and trends over a period of time. They could look at what's going on.
Certainly be good for high-level planning, national planning, national initiatives, programs.
I think anything we can do that reduces the burden for teams locally, that's got to be a good thing.
Yeah, even if it only pre-populated what the extra information you're giving on a monthly basis.
Yeah. Infection control teams could get more and more given to them, and it's a finite resource they've often got, so they've got to judge what they're going to do. So anything that's going to be more efficient would be welcome. Phil, I remember a few years ago we did some work, and I think it was 1/3 of ICP time, infection control professional time, was spent undertaking surveillance and audit activities. So that's a lot of time, and presumably then if we can reduce that down a little bit, it would have a big benefit.
Yes. Yeah. 30%, I think it was, 25 to 30% of their time generally spent on surveillance activities.
Yeah.
I'm sort of of the opinion that what we know about surveillance now is going to change dramatically in the next few years.
Completely agree.
These pilot studies are okay, I think, for the time being, but I think the advent of AI and EMR is just going to change surveillance dramatically. Totally dramatic.
Totally.
Completely.
Yeah, and I completely agree. So it's worth doing, I think.
Yeah.
To actually look at what the bottlenecks in the systems are and the inconsistencies. So I'm glad they did it, because it shows you can't just wave a magic wand and say,
Yeah, it's no
we
easy
can
fix.
automate it.
Yeah.
From tomorrow, we start tomorrow. Let's take a bit more work. And it sounds
Now,
like
now it sounds like we've got a big crowd who've just arrived to our Fetch Commoners podcast. There's about 40 people now looking at us. So
They've come to listen.
They've come to listen, and it's getting noisy in here. So we're going to sign off.
Okay.
I think on that note.
Yes.
Thanks, Phil. Thanks,
to
mate.
see you.
Yeah.
Yeah, thanks, Rob.
Good to see you.
Okay.
Good to see you both. Bye.
Ciao.
Catch you later.